So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this online event jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation USA chapter. So, the focus of today's session is TE quantification of aortic stenosis and aortic regurgitation. Well, to start with today's Sunday TE session, I would like to present before you a short welcome video.
Good morning and welcome to the Sunday TE breakfast session with echocardiography. We deal with transesophageal echocardiography and critical care echocardiography to benefit large number of interested specialists in this field. This event is being conducted under the auspices of the Karnataka chapter of IACTA, that is the Indian Association of Cardiothoracic Anaesthesiologists, IACTS, that is Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, Global Heart Foundation, and thank you for joining us. And we would like to invite Dr. Poonam Malhotra to moderate this talk today, and Dr. Anuradha, who is my colleague in Narayana, will be with you for the next 1 hour or so. And please put all your questions and comments in the chat box. And if you would like, you can unmute yourself at the end of the talk and directly speak onto the microphone and then clarify your doubts or make some comments if you would like to. So with that short introduction, I would like to invite Dr. Poonam Malhotra, who is well known, really does not need any introduction. She's almost an international figure in the field of cardiac anesthesia, echocardiography, and ECMO. With this, I would like to request Dr. Poonam Malhotra to introduce Anuradha and then carry on with the session. I'll be there till this end of the session, and we would wish to finish by 10 o'clock so that you can enjoy your Sunday. Thank you so much.
Thank you, Dr. Mullidhar. It's a pleasure to join all these young upcoming echocardiographers for this beautiful Sunday breakfast session. It's a very good thing to learn early morning from your experience and make your skills better. Today, we have a very, very good speaker with a young coming consultant from Narayan Hridyalaya, who has been a fellow of echocardiography and then has upgraded her skills to become a consultant at NH itself. Dr. Anuradha would be speaking today to us on a very pertinent subject of transesophageal echocardiographic involvement of the aortic valve. Now, the aortic valve pre-surgical assessment includes a lot of evaluation of the aortic valve anatomy. As an anesthesiologist, perioperative physician, as an echocardiographer at the helm of affairs, to tell the surgeon whether my aortic valve is repairable or does it need a replacement is a very daunting task. And at that time, when you're alone in the OT, if you do not know the aortic valve anatomy well, if you do not know where to rule out AR with an AS, and if there is a mixed lesion, it becomes quite a challenge. And even more difficult is then how to quantify this aortic valve. So identification of all the coronary arteries around the aortic valve, evaluation of the aortic valve function, and assessment of associated lesions, and particularly how does it affect left ventricular function as well. Many ARAS cases coming for whatever procedure, we are in a peri-procedural intervention phase in the cath lab today with TAVI and towers happening all around us, and we are called upon to do so. Our young speaker today is one such person, multifaceted, with the task of handling tower in the cath lab and all the aortic valve procedures for this with the cardiac surgeons in the OT. Over to her to speak to us about TE of the aortic valve, both AR as well as AS. Over to you, Anuradha. Welcome to the Sunday Breakfast Show.
Good morning, everyone. 1 second. I'll be sharing the screen. 1 second. Good.
Yes, your screen is well visible, Anuradha. Please
yes,
proceed.
Sir. Yes, ma'am. 1 minute. Good morning, everyone. Myself, Dr. Anuradha Devtale. My topic of presentation today is T quantification of aortic stenosis and aortic regurgitation. One second, ma'am. That slides up. So when we are assessing the aortic valve, what all views we need to see? I'll just explain in short. First view which we need to assess is the mid-esophageal aortic valve short axis view, which we see at 45-degree angle. So aortic valve in this figure, the aortic valve is in the center of the screen with 3 aortic cuffs appearing symmetric. In you can see the left coronary cusp, the right coronary cusp, and the non-coronary cusp. The non-coronary cusp will be near the interarterial septum. So in this, you can assess the aortic regurgitation if it is present. So in systole, the aortic valve will show flow during systole without flow in diastole. If there is any regurgitant flow, we can find, we can see in this figure whether there is a commissural leak or where there is a central regurgitation. The next view which we see is the mid-esophageal aortic valve long axis view, which is at 120 degree. In this, we can see the right coronary cusp, the non-coronary cusp, the right coronary cusp near the right ventricle, and the non-coronary cusp or the left coronary cusp near the posterior wall. Here you can assess the normal cusp coaptation during diastole. You can measure all the aortic root measurements can be done here. You can assess the subvalvular, valvular, or the supravalvular obstruction. The next view is the 5-chamber view, which is seen when you see the 4-chamber view, you slowly withdraw the probe. We get the 5-chamber view in which you can see the right coronary cusp and the non-coronary cusp. You can see the entire LVOT here. The next view is the transgastric long axis view. This here also you can assess the left coronary cusp and the non-coronary cusp. In this view is very important for the Doppler measurements and to assess the mechanical aortic valve because the shadowing will be less in this view. This is the deep transgastric view. In this is the right coronary cusp and this is the non-coronary cusp. In this, all the Doppler measurements can be done and you can see any paravalvular leak present and all the prostatic valve function can be done in this view. Now coming to this aortic valve mid-esophageal short axis view. In this, I have shown the 2D and the 3D and the surgeon's view. So this is the normal 2D image. And when you rotate the 2D image to 90 degree, you get the surgeon's view. This is the surgeon's view and this is the 3D image. Now coming to aortic root dimension. So according to AAC guidelines, which suggest measurements can be made during different points in the cardiac cycle using mid-esophageal aortic valve long axis view. In this view, you have to measure the aortic height, which is normally less than 22 mm. This is the horizontal distance between the sinotubular junction and the aortic annulus. So in TAVI procedures or the valve sparing procedures, this root height is very important. So normal annulus is around 26 mm. The sinus is around 34 mm. The sinotubular junction is 29 mm and the aortic is 30 mm. So in systole, we measure the annulus and the LVOT. And during diastole, you will measure the sinotubular junction, sinus of Valsalva, sinotubular junction, and the ascending aorta. Now coming on to bicuspid aortic valve. Most of the time we will see in patients there will be the bicuspid aortic valve. So what we need to assess in this? So when there is a bicuspid aortic valve, it can be congenital or it can be acquired. In congenital fusion, there will be left and right cusp will be fused in 86% of the cases, and in right and non-coronary cusp will be fused in 12% of the cases. In acquired cases, there will be unequal cusp size from fused commissure. So Seaver had classified this on the base of the raphe. So in type 1, both the coronaries will be on the same side of the orifice, and in type 2, the valve orifice will separate the coronaries. Now, what all we need to see in the bicuspid aortic valve? So the number of the aortic valve cusps is determined during systole in the mid-esophageal aortic valve short axis view. So it opens in a triangular orifice and the 3 commissures are seen. In the bicuspid aortic valve, the orifice appears oval or a fish mouth with only 2 commissures. But during diastole, a bicuspid aortic valve raphe will make the Mercedes sign like a normal aortic valve. The normal aortic valve cusp open and close in the center of the sinus of Valsalva in the mid-esophageal aortic valve long axis view. But in the bicuspid aortic valve, the cusp open during systole is often eccentric and the cusp appear domed, like which is shown by an arrow from incomplete opening. This is the during diastole, the cusp coaptation line may be eccentric from the different cusp sizes and the body of the cusp may prolapse during diastole. So these are the diagrams which shows the systolic doming. Then what are the main points we need to see is the systolic elliptical orifice opening in short axis view, systolic cusp doming in long axis view, diastolic eccentric closure line in long axis view, and diastolic doming cusp prolapse in the long axis view. Next is unicuspid aortic valve. So it can be unicommissural or acommissural. This is the diagrammatic representation how the unicuspid aortic valve looks. Next is the quadricuspid aortic valve. It is the rarest, like it is in 0.013% of the patient. There are 7 anatomical variants which is seen. It can be associated with other congenital diseases like VSD, ASD, PDA, or subaortic membrane. So you have to see for other anomalies also. These are the 7 variants how the quadricuspid aortic valve looks. Then coming on to the assessment. So we have to first see what is the etiology, whether it is a valvular, subvalvular, or a supravalvular. So if it is a valvular, we have to find out whether it is a degenerative, calcified, rheumatic, congenital, or bicuspid. Then coming to subvalvular, whether there is any membrane present, HOCM is there, or SAM is there. Then supravalvular, you have to see any congenital ascending aorta narrowing is present or not. Then coming on to 2D findings of the aortic valve. So we have to find out the etiology, whether it is a degenerative or a rheumatic. Then any calcification is there or not. Then the restricted cusp opening of one or all the cusps. So only one cusp is involved or all the cusps are involved. Then you have to see whether it is a tricuspid or a bicuspid. Then you have to, by planimetry, you can calculate the area. But if there is calcification, it is always underestimated. Then the aortic annulus size, root dimensions in diastole, and the location of the coronary ostia. Then coming on to Doppler, what we see the color. When we put the color in the Doppler color, when you see the turbulence at the level of obstruction, then pulse wave will locate the level of obstruction. And when you put a continuous wave, which I've explained in deep transgastric view, you can measure the peak, mean velocity, and the pressure gradients. This pressure gradients will be underestimated if there is a less LV, if it is a low LV function, MR is there, or poor Doppler alignment is there. It is overestimated if there is a high cardiac output. Now, if LVOT peak velocity is more than 1.5 meters per second, or aortic valve peak velocity is less than 3 meters per second, then we can use a modified Bernoulli's equation, which is for peak velocity of the aortic valve square minus LVOT peak velocity square. Then we have to measure the stenotic severity, which I have explained it later. Then what are the associated findings, like whether there is a LVH, RWMA, poor LV function, or any mitral regurgitation or calcification. So now what we have to tell the surgeon? So pre-bypass and post-bypass, what we will tell? We will tell the etiology, whether it is rheumatic, calcified, or bicuspid. We'll measure the annulus size. Then we will calculate the area to avoid the prosthetic mismatch. Then aorta will see any post-stenotic aortic dilatation is there, any calcification is there. Then location of the coronary ostia, calcium bar, LVH, whether it is concentric or not, LV function, and septal hypertrophy. Post procedure will see, like post bypass will see prosthetic valve stability, leaflet mobility, any paravalvular leak, mean peak gradient across the valve. There should be no LVOT obstruction with SAM or any VSD which is left, then LV and RV function, and intercavitary gradient. Then coming on to the assessment of the aortic valve severity according to the AAC guidelines 2017. So peak velocity, if it is more than 4 meters per second, mean gradient it is more than 40, aortic valve area less than 1 meter per second, aortic valve area less than 1 centimeter square, indexed aortic valve less than 0.6, and velocity ratio, which is also called the dimensionless valve index. If it is less than 0.25, then these are all the criteria for severe aortic stenosis. Now, how you will classify whether it is a calcified aortic valve, rheumatic aortic valve, or a bicuspid aortic valve? So when it is a calcified aortic valve, which is shown in this figure, you see a fibrocalcified changes to the body cusp. Okay, it will be thick, steep cups with heavily calcification, irregular orifice, and rarely there will be a commissural fusion. But in rheumatic, there will be in calcified aortic valve, there will be no fusion of the commissure, but in the rheumatic, there will be a commissural fusion. It will be thick calcified free edge, calcified nodules on both surface. Then there will be caudal shortening, and most of the time mitral valve will also be involved. Then coming on to bicuspid aortic valve, which I have explained before also, it is asymmetrical cup size, raphe often present. The body will be completely calcified. You'll see a fish mouth appearance, and other aortopathies will be present. Then how we measure the velocity and the pressure gradient? So to measure the transaortic pressure gradient between the left ventricle and the aorta, it should be done in systole. So you have to trace the outer edge so when you put a Doppler in the deep transgastric view, you will get a graph like this, and then you have to trace the outer border. In this, it is called a double envelope technique. So it is if you trace the inner border, it is the LVOT, and when you trace the outer border, it is the aorta. So you have to trace the outer edge for the VTI and the pressure gradient. You will get the mean and the peak gradient. The peak instantaneous pressure gradient is estimated by the Bernoulli's equation. So in simplified Bernoulli's equation, the pressure gradient is equal to 4V square max. But when the velocity proximal is less than 1 meter per second. But if the velocity is more than 1.5 meters per second, or the aortic velocity is less than 3 meters per second, then you have to go for modified equation. The peak-to-peak pressure gradient obtained from the cardiac catheterization is always lower. Then we measure it in the echo. But the mean pressure gradient will be always equal. So mean pressure gradient is more accurate than the peak pressure gradient to quantify the aortic stenosis. Now coming to how we calculate the aortic valve area. So first is the planimetry method. So you take the mid-esophageal aortic valve short axis view. You have to trace the aortic valve orifice during systole, and this will represent the anatomic aortic valve area. But if there is lot of calcification, it is very difficult to measure the area. It will always underestimate the area. Then this is the velocity. Second is the velocity ratio. In this VTI of the LVOT and the VTI of the aortic valve, if the ratio is less than 0.25, it indicates severe aortic stenosis. This is a dimensionless number, so it is independent of flow, which represent the size of the effective aortic valve area. It can be used to assess the aortic valve severity even in poor left ventricular function. So VTI LVOT upon VTI aortic valve. Then how we measure the aortic valve area with the continuity equation. So for that you need the LVOT velocity. So when you put a pulse wave Doppler in the deep transgastric view, you get a smooth velocity curve like this. So you have to trace the outer border, and then you will get the VTI of the LVOT. Then we have to see the diameter. So for that, you have to take the mid-esophageal aortic valve long axis view, this view, and you just below the annulus, 0.5 to 1 centimeter below the aortic annulus. When you take the diameter, you get the LVOT diameter. Putting both the values in this aortic valve area equation, LVOT VTI, which we have calculated by putting the pulse wave Doppler, and then putting in this formula 0.785 D square. So D square, whatever value we get by measuring in this LVOT diameter, this diameter you have to divide by 2 upon the VTI aortic valve. So you will get the aortic valve area. The next, this is very important, this is low gradient aortic stenosis. So when the patient has a very low EF, so low gradient aortic stenosis may occur with a low EF or a normal EF. So low EF aortic stenosis is defined as the aortic stenosis in which the valve area is less than 1 centimeter per second with transvalvular mean pressure gradient less than 40 and EF is less than 50% and stroke volume index is less than 35. In this, when there is a dilemma of why the gradient is low, we have to start dobutamine. So dobutamin's test echocardiogram helps differentiate to see whether the reduced cups opening is a true AS or it is a pseudo AS. So by increasing the dose of dobutamin, like from 0.25 microgram to 20 microgram per kg per minute, will change the stroke volume, altering the aortic velocity, mean pressure gradient, and the aortic valve area. The true stenosis will not have any increase in the aortic valve area or the pressure gradient. But when it is a pseudo stenosis, you will find definitely increase in the aortic valve area by 0.3 centimeter square, or aortic valve area size will increase more than 1 centimeter square. So when there is a low velocity, low gradient, you have to see this criteria. Like if the aortic valve area less than 1, EF less than 50, mean pressure gradient less than 40, and the aortic stroke velocity index is less than 35. Now coming to aortic regurgitation. So for assessing aortic regurgitation, what you will tell the surgeon pre-op and the post-op. So pre-op, you will pre-bypass, you will tell them what is the mechanism, whether the root is involved or is there any valve pathology, and calculations of the dimension of the aortic root. Then the cusp, how many cups are involved, the morphology is how, whether the coaptation is proper, whether the leaflet is prolapsed, frail, whether there is calcification or whether there is any fenestration. Then you have to locate where is the AR and the direction of the AR, whether it is central, whether it is eccentric, or whether it is commissural. And you have to see whether the aortic regurgitation, how severe it is. Then whether we can do a Ross procedure or not. This all we have to tell the surgeon pre-bypass. Post-bypass will tell like whether the whether when they have done a valve sparing surgery, the cups coaptation is above the annular plane. If they have put a prostatic valve, we have to see the function gradient, whether there is a paravalvular leak, and we have to see the LV function. Now, according to the Alcoris classification, he has divided into type 1, type 2, and type 3. So type 1 is usually the cups are normal and the coaptation will always occur above the annulus in the sinus of Valsalva. So these are subdivided into A, B, C, and D. So whether there is a dilatation of the sinotubular junction or whether the sinus of Valsalva is dilated, annulus is dilated, or there is a cusp fenestration. In type 2, if there is an excessive cusp motion and the body falls below the aortic annulus, so it is called prolapse or failed cups. Then whether there is a restricted cusp motion, which results in central coaptation of the cusp, which is rheumated or calcification. So for quantifying the aortic insufficiency, the ASC guidelines has divided into quantitative, semi-quantitative, and quantitative measurements for assessing the severe aortic regurgitation. So if the jet width is in the LVOT is large, it is severe. Flow conversion, if it is large, then you have to see the continuous wave graph velocity density. Then if the pressure half time is less than 200, when there is a holodiastolic reversal in the aorta, this will all suggest severe aortic regurgitation. When the vena contracta is more than 6, jet versus LVOT cross-sectional area, if it is more than 60%, jet to LVOT width, if it is more than 65%, then regurgitant volume fraction, if regurgitant volume is more than 60%, regurgitant factor more than 50%, and effective regurgitant orifice area, if it is more than 0.3, this all suggests that it is a severe aortic regurgitation. But when we are doing all this calculation, always remember the Nyquist limit should be around 50 to 70 centimeter per second. So what all views we need to see to assess the aortic regurgitation? It first is mid-esophageal 5-chamber view, mid-esophageal aortic valve short axis view, mid-esophageal aortic valve long axis view, transgastric long axis view, and the deep transgastric view. So how we can differentiate whether it is a central jet, commissural jet, anterior jet, or a posterior jet? So in this figure, this is the central jet, this is the commissural jet because it is leaking from the commissural, it is anteriorly directed, and this is posteriorly directed. This is anteriorly directed because it is coming in the anterior wall, and this is directed towards the posterior wall. It is a posterior jet. So normal cuff coaptation will always occur above the annular plane in the sinus of pulse valve. This is very important. Then if the prolapse, when we say the prolapse, when it is below the annulus, so it has been divided into whether it is a fail, whole, or a partial. So when we say it is a fail, when only the tip is in the LVOT, when the whole edge is in the LVOT, you say the whole prolapse is, segment is prolapse. When there is a partial prolapse, when the cuff's only body is in the LVOT. Then how to calculate the jet area or the height? So keeping the Nyquist limit at 50 to 60 centimeter per second, the ratio of the jet height to the LVOT height, which is called the Perry's index, we measure both the diameters, and then we calculate like whether it is less than 30, 30 to 50, or more than 50%. If it is more than 50%, it is a severe. So this color measurements can be made from a color M mode, provided the cursor is aligned as parallel as possible to an aortic valve. The color jet height is divided by the LVOT height at the same level within 1 centimeter below the aortic valve in the mid-esophageal aortic valve long axis view. In the similar way, we can calculate the jet area, but instead of using the mid-esophageal aortic valve short axis view, we take the cross-sectional area of the jet and it is divided by the area of the LVOT. So I put a color M mode, and you can see this is the regurgitation, and we compare it with the LVOT diameter. So we take this diameter at the same point and the LVOT diameter, and accordingly we calculate the percentage. Then vena contracta. What is vena contracta? The narrowest portion of the jet at or just downstream from the orifice. You'll see the laminar flow and the highest velocity. So vena contracta size is independent of the flow rate and the diving pressure from a fixed orifice, but may change with the dynamic orifice. So if the vena contracta is less than 3, it is mild, but if it is more than 6 mm, it is severe. So the narrowest portion, when you see of the regurgitation, like here, see, we have to measure that, and if it is more than 6 mm, it is severe regurgitation. Now, what is flow convergence or the Nyquist variable? So high velocity flow, termed flow acceleration, proximal to the regurgitant wall orifice, result in series of the concentric hemisphere. We have to adjust the Nyquist limit, like we have to come down from 60 to around 40, 35. So at the point where you get a nice concentric hemisphere, so usually we get it at 40. And then with the PISA method, like calculating this, and then you can calculate the radius, and from that you can calculate the regurgitant, effective regurgitant orifice area. So from this PISA, you can calculate regurgitant volume fraction and the effective regurgitant orifice area. I have explained it further. Now, how to calculate the effective regurgitant orifice area? So this is the derived area of the hemodynamic regurgitation. corresponds to vena contracta cross-sectional area, the narrowest portion of the jet, which is slightly smaller than the anatomic orifice. So effective regurgitant orifice area is, we can calculate either by PISA method or the volumetric method. So when you are calculating by PISA method, I have told you we have to come down on the Nyquist limit and you get a nice hemisphere. So from the narrowest portion, you have to measure the outer border of the hemisphere, you get a radius. That radius, you will put it in this formula, this R square. So what is the flow across the aortic insufficiency is 2 into 3.14 into pi into R square and into VR. VR is the aliasing. So for it 40, if you get a nice velocity, you should put 40 here and then you will calculate the aortic insufficiency flow. So this flow has to be divided by peak velocity. So whatever aortic regurgitation you get, you have to calculate the peak velocity. That peak velocity, you will put it in this formula and you will get the effective regurgitant orifice area. Now coming to the volumetric method, to calculate the regurgitant volume, we can calculate by this formula by calculating the stroke volume of the aortic valve, and we have to minus it by the stroke volume of any normal valve like the mitral valve, and then you will get the regurgitant volume. Now calculating the effective regurgitant orifice area, this regurgitant volume you have to divide it by VT of the aortic insufficiency. So this is the formula to effective regurgitant orifice area is 2 pi r square into aliasing velocity, and if it is not 40 or if it is any angle indifferent, if the hemisphere is not proper, then that angle difference you have to divide it by 180 degree. So this is like this you will get the hemisphere. From this narrow point you have to just take a radius and you have to put it in this formula and calculate the effective regurgitant orifice area. Coming to the regurgitant volume is the volume through the effective regurgitant orifice area, and it can be calculated by the PISA method or the volumetric method, which I have already explained. So regurgitant volume is the effective regurgitant orifice area into the VTI. So regurgitant volume will be centimeter cube, and regurgitant volume, the other way is by calculating by stroke volume. So stroke volume of the aortic valve minus the stroke volume of the normal valve. So for calculating the regurgitant fraction is the fraction or the percentage of the total stroke volume that regurgitates through a incompetent valve. So regurgitant factor is stroke volume through aortic valve minus stroke volume through normal valve upon stroke volume of aortic valve. This is the formula, and multiplied by 100, you will get the regurgitant factor. If it is more than 50%, it is severe. Now when you put a continuous wave Doppler in the aortic valve, you will get a nice trace of the aortic regurgitation. So if this initial peak gradient is more than 40 mmHg and the velocity is more than 3 meters per second, this will tell like it is a severe aortic regurgitation. Then you have to see the slope, whether it is a denser slope. You have to see the slope, whether it is a steep slope or it is a flat slope. If it is a steep slope, that means again it is indicate a severe aortic regurgitation. Then you have to see that whether the envelope we get is dense or it is empty. If it is dense, completely filled, then also it is severe aortic regurgitation. So you have to see the rate of decline of aortic regurgitant jet, and this can be quantified by measuring pressure half time and the slope of deceleration. So if there is a larger effective regurgitant orifice area, it quickly equalizes pressure between aorta and the left ventricle and creating a steeper slope in the regurgitant velocity and shorter pressure half time. Then other method of estimating the regurgitation is by putting a pulse wave Doppler in the descending aorta. So when you get a diastolic flow, holodiastolic flow reversal, that also signifies it is a severe aortic regurgitation. This diagram will show, see, when it is a flat top, it is indicates mild. The pressure half time, if it is more than 500, it is also indication of mild. In severe, you see, it is a stiff slope. So the pressure half time will also be less than 200. So this indicates it is a severe aortic regurgitation. And when you are putting a pulse wave Doppler in the descending aorta, see, this is a normal graph which you will get by putting a pulse wave in descending aorta. But when there is a graph like this with the holodiastolic reversal, this indicates it is a severe aortic stenosis. Thank you.
Excellent, Anuradha. You were absolutely to the point and very, very pertinent in everything that you told us about the quantification, particularly of the aortic valve, what to look for. I don't think we have much to add. I would just like to add two things. One of them is about the qualification of the aortic valve, particularly for AR as well as for AS. Now, for you, very beautifully, you described the El-Khoury assessment, type 1 to type 3 of the the leaflets of the aortic valve. You said that there is type 1, which is just plain collapsing or dooming, then type 2 is into A, B, C, D, and you describe the 3, A to D, and there's a type 3. Now, just want a take-home message for all of you that in general, when we are quantifying the aortic valve and telling the surgeon about the repairability versus the rootability of the VSD with a subaortic membrane and a AR, what we really look for is what is known as the functional aortic valve area, or the functional aortic root as it is called. And this functional aortic root, there is I think a article very beautifully written. This is also a question in the chat box, which is written by none other than people, seniors and juniors from Sri Chitra Tirunamul. This is in Annals of Cardiac Anesthesia, January 2024. It's something on the chronic AR and how to quantify it. And there they describe very beautifully what is the functional root, aortic root. It is that area between the sinotubular junction and where the aortic valve leaflets coact. That is also your functional aortic valve anatomy, and that incorporates your commissures, that incorporates your triangles, that incorporates your entire leaping, prolapsing, fenestration. All the pathology that happens in that area. It's the dynamic functional area, which is most important, which is all the time changing when the AR becomes from acute to chronic. So when it is type 1 or type 2, and this article also describes it, it is a repair, and generally in type 3, it will be a replacement. So that was one thing that I just wanted to add, that you must know a few indices and a few classifications that she spoke about. Another very, very pertinent part that is important is for all of you to know the difference between, from the exam point of view, from your functional test point of view, which you may be taking for any fellowship, is to know very well what is the difference between the qualification and the quantification. Like the shape, she talked about the dagger shape, the severity, the concentric dagger shape, and the concentric AS with the LVH that you see is very, very pertinent. The denser and the more dagger shaped your trace is on continuous wave Doppler, the more severe is your AS. So your qualitative function of what you are seeing is the calcification there. Is it a pinhole sized AS? Is it an inadequate short axis view that you're seeing of the aortic valve? As she beautifully pointed out, Ionicus limit between 50 to 70 is your aliasing velocity, not showing a foreshortening or an artifact of any kind. These are important parameters to have. Always rule out an LV hypertrophy. The left ventricular function assessment with an aortic valve pathology is equally important, particularly when it is an AS or a chronic long-standing AR coming to you, and you have a mixed lesion which is going to be replaced by the surgeon. You must quantify the LV hypertrophy. You must see in a long-standing AS what is the degree of the diastolic dysfunction that you have. And is after the AVR is done, if there was a systolic LV dysfunction or the diastolic pseudo-normal, let's say type 2, has it become better or has it worsened? Sometimes it may worsen if the wrong size of the valve is set. She talked very nicely about the grading of the aorta. But for qualitative evaluation of AS, which is a very small pertinent part, you must remember the two most views. She beautifully told you all the views, but two most important views are both the mid-esophageal views, the long axis as well as the short axis. And you must see the leaflet thickening. You must see the leaflet dooming, the fusing of the leaflet. How are the commissures? How is the iotomitral continuity? And you must see the calcification. Then a very pertinent point on qualitative examination is you see the leaflet separation. If you see, that's what I do. Normally, I just have a look and I've got used to with experience. I just come in, see my velocities, and I see rule out a foreshortening, do a short axis view, and then go on to 120, the long axis view of the aortic valve. I see the leaflet separation. Is the leaflet thickened? Is it flail? Is it prolapsing? And if there is a small cleft in the leaflet, more often in the mitral leaflet, but sometimes also in the aortic leaflet. And how much is the leaflet separation? In a normal thing, it should be less than 15 millimeters. But if it is more than 12 millimeters, it is a mild AS. If it is between 8 to 12 millimeters, the leaflet separation is decreasing. You've got to see the decrease in leaflet separation. It is a mild or moderate AS. And if it is definitely the leaflet separation is less than 8 millimeters, it means it's a severe AS. So you see the leaflet separation, you see the leaflet area. Someone has asked, how do you, she explained very nicely in one of her things. She can go back and I will request Anuradha to explain. One person has asked, how do you calculate the aortic valve area? How do you do the planimetry of the aortic valve area? Anuradha, can you go back to it and tell them about it in the chat?
Yes, ma'am.
Yeah.
Yes, ma'am.
Those were some important, by the time she comes out, those were important points to remember. Always see a quadricuspid, a bicuspid, or a tricuspid aortic valve. And always do see the iotomitral continuity. It's a very important part, especially when we have RSOV.
Thank you very much. As Anuradha is getting the slides put up again, it was nicely done. All the major points were covered. And she did mention that the estimation of aortic valve area by planimetry, when the valve is calcified, it will be underestimated. The valve area will be underestimated. So you have to use other techniques to determine the aortic valve area. One of the other techniques is the continuity equation, where you measure the aortic valve VTI and the LVOT VTI and get the LVOT area estimated by measuring the diameter of the LVOT. And by substituting the values, you will get the aortic valve area by continuity. You ready?
Yes, sir. Yes. So we have to go in mid-esophageal aortic valve short axis view for measuring the aortic valve area. In systole, you will trace, 1 second, I'll on the pointer. 1 second.
We're not seeing the slide.
You are not, 1 second, sir.
Also, meanwhile, when she comes on, Anuradha, just point when you come on.
Yes, ma'am.
What article to read? Do read, all of you, this article by our own authors from Chitra. It's a very nice short article on quantification of chronic AR and how to not to toll the AR unnecessarily with T is another article. I don't remember which article it has come up, but when you do transcatheter aortic valve interventions, they say the role of a CMR or a CT scan supersedes the role of a TE. So when not to use TE and when to use TE, we'll talk about it later till Anuradha gets ready. She's got ready. Over to you, Anuradha.
Yes, ma'am. So when you come to mid-esophageal aortic valve short axis view, you get this view, and in systole, you have to just go to trace button on that echo machine, and you have to trace the borders of this like this, and you'll get the aortic valve planimetry area. You can calculate according to this. But when there is calcification and all, it is very difficult, and it is always underestimated. So just trace the inner borders and you'll get the aortic valve area by the planimetry method.
Yeah, that's right. The normal aortic valve area is 3 to 4 square centimeters. It is 3 to 4 square centimeters. Easy to remember. Mitral valve, it is 4 to 6 square centimeters. And tricuspid is 7 to 9 square centimeters.
Also,
So
as she said, the
yeah.
short axis view is one of the best views to rule out a pinhole AS as well. Sometimes the aortic valve planimetry area is so small that all the leaflets are calcified and so are the commissures, and you
Yes.
have a typical pinhole AS. And you may not be able to see the same on a long axis view. When you go to 120 and beyond, you'll be able to see the leaflet coaptation all fused up, and you will say that, oh, my area is normal, but actually it is the short axis view that gives a better view of the quantification of the aortic valve planimetry than the distance in diastole between the two leaflets in the long axis view. You could do that also and give them the value of the annulus, but that is a better value of the annulus that you see. You see three major values there: the aortic valve annulus, you see the aortic root, you see that sinotubular junction, and beyond the sinotubular junction, you could also do the diameter of the ascending aorta at the point beyond the aortic root. So those are important sites of measurements of the aortic valve. You must know the difference between aortic root, the sinotubular junction, and the ascending aorta and the aortic annulus. It's the first one is the aortic annulus, and you prefer to do it in end diastole rather than end systole. There are different books mentioning different things. There is also a question on the book. I love the book called Savage. Everyone has a host of books to come up with, but I think Sidebotham and Perino are very good TE books to read. From the examination point of view, after you've read a textbook like Savage, if you're taking multiple fellowship exams in echocardiography, a very holistic book for aortic valves, both the chapters, is the Valvular Heart Disease book by Alpert. Right from the echo to the pathophysiology to the functional anatomy of the valves, it tells you everything. So first read your Alpert and then go on to Savage and then read the Perino or Sidebotham, whatever you've chosen. And do read one or two recommended articles. That's from my side. I'll wait on for Dr. Mullidhar. You were saying something.
Thank you. Thank you so much. Thank you so much. There's a question on how to differentiate rheumatic and degenerative aortic stenosis. I hope it refers to stenosis. Radha, would you like to address that question? How do you differentiate rheumatic aortic stenosis from degenerative aortic stenosis?
Sir, in rheumatic, the commissures will be fused. It will be thick, calcified, free edges. There will be calcified nodule on both surfaces. There will be caudal shortening, and the mitral valve will be involved. In degenerative, it is always age related. So it will be thickened leaflet. It will be not so much calcification will be seen. So you can easily differentiate by seeing the image whether it is a rheumatic or it is a degenerative.
Also,
Yeah.
in degenerative, sometimes like we have a floppy valve syndrome or a myxomatous valve syndrome or a amyloidosis or Fabry's disease. These are some connective tissue disorders that you may see more in the Western population than the Asian population. But a rheumatic disease will always show more of calcification. The valvular structures beyond the valve being floppy or degenerated with age would be more seen in other degenerative disorders like the myxomatous or the Fabry or the amyloidosis. Amyloidosis has a sudden onset. A degenerative is because of disease. But sometimes most of these show more of a generalized connective tissue disorders which may affect other areas also beyond the valve. In rheumatic heart disease, it will be restricted, more localized around the valve, and one or two valves of the heart would be affected along with the joints. So you've got to rule out your major and minor criteria, rule out Oslo's nodes, rule out erythema marginatum, all those that we learned about the major and the minor Jones criteria. But more than anything, see your CRP levels, rule out many things. If you're just pointing out to the rheumatic etiology on TE, then always rule out calcification in all joints. That is the hallmark of rheumatic disease. Whereas in degenerative disease, there'll be a generalized connective tissue disorders affecting all other chambers of the heart, not just the valve. That's what that.
Yeah. The degenerative calcific aortic stenosis occurs in the elderly age group beyond 65 years. In fact, the incidence is 25% of all adults who are more than 65 are expected to have this. Aortic sclerosis is also the milder form of aortic stenosis, but where there is no gradient, but the valve leaflets are thickened. And when the valve area comes to less than 1.5, then it becomes less than 2.5 to 1.5 will be mild aortic stenosis, 1.5 to 1 will be moderate, and less than 1 square centimeter will be severe aortic stenosis. In rheumatic heart disease, the calcification starts from the tips of the leaflets, whereas in the degenerative thing, it is in the body. And usually the commissures may be sprayed in the degenerative disease, whereas the commissure infusion is invariable in rheumatic heart disease. Is that right, Anuradha?
Yes, sir.
And there's one other question, aortic valve assessment, TT versus TE. What is your reply to this? Another 4 minutes to go.
Anuradha, if you are taking your time to answer, I'll just say that there are some structures because of the superior quality of imaging in TE over TTE. Many people will do a non-invasive TT, especially the cardiologist will do a TT and send the patient. But what is the cause of the AR? What is the functional subset leading to the AR? Because of its better imaging, a TE tells much, much better. So you may need both a TT and a TE, and definitely a TE when you're coming in the peri-op period for a surgical intervention on the aortic valve. It could be a cath lab intervention as well. And when you need a TE, it tells you over and above a TT, what is the functional defect in the aortic valve, which a TT will just tell you or quantify the AR for you, quantify the AS. But the moment you see the AR or the AS, further detailed quantification, the functional subtype, how the functional deformity has happened, how does it affect other chambers of the heart? Not that a TT does not tell, a TT also does tell, but I personally feel AS over AR, you need a TE more than TT. A TT is good for both, but the functional subtypes is better with a TE over a TT because of its superior image quality.
Yeah, I agree with that because of the proximity of the esophagus to the aortic valve. You can get very, very good resolution of the aortic valve, and you will be able to see the valve much better than TT. Only thing is, in TEE, you have to go to transgastric views and deep transgastric views to get the gradients because of the alignment of the echobeam, and the blood flow must be absolutely parallel as far as possible. So that is one thing which we cannot do in mid-esophageal views when you're using the TE.
Especially in a patient who's prone to arrhythmias, or a patient's coming with a mitral valve disease in AF, or is having some stasis in the LA, or has a spontaneous echo contrast. Many people would like to quantify the images better over and above a TT into a TE.
Right.
And there is very often, they say, a rule of 55, which is asked also in the exam before we close, and that would be my last comment. And my last would be to congratulate Anuradha. But the rule of 55, she talked about less than 30%, 35% ejection fraction. But when your ejection fraction is less than 55% and your left ventricular end systolic area is becoming bigger than 55, that is the time when your surgical outcomes will be deterred too. So those are the times you should be very, very careful. Do always measure the LV assessment, rule out the LV hypertrophy, rule out the LV ejection fraction becoming less than 50 or less than 55 particularly, and also keep seeing your LV end systolic pressures, whether they are becoming, we see more of volume than the pressures. Pressures are indirectly calculated on TE. But whatever you are seeing in terms of the pressures or the volumes, always see that it should be less than 55 or more than 55 systolic pressures, your surgical outcomes will be worsened. So those are the patients requiring higher inotropes and higher vigilance in the ICU post-surgery. That's all from my side. Thank you, Dr. Mulithir. And
Thank you
heartiest
so much.
congratulations, Anuradha. You did a wonderful job. Truly proud of the way you presented. Do come on for more such breakfast sessions for this forum.
Thank you so much. Thank you for joining us. Thank you, Dr. Poonam Malhotra and Dr. Anuradha, for spending your valuable Sunday time with us this morning to educate us about the aortic valve and the lesions, stenosis, and regurgitation assessment. Thank you very much. And I request Rituparna to play the ending video.
Sure,
This
sir.
is about the TE workshop in August. Dates are 21st to 24th. Please join us. It will be of a high quality in-person meeting, workshop come CME, and thank you so much. And Ritu, please carry
Yes,
on.
Thank you.
Thank you all.
Thank you, sir. Thank you, ma'am.
Thank you. Good luck and see you next week.
Thank you, sir. Thank you.
dear
Bye.
doctors.
Bye.
Thank you, dear
Thank you,
doctors, for
sir.
sharing your valuable insights. So with all your permission, we are signing off for today and looking forward to host you on the next day. Thank you. Goodbye. Take care, everyone.